Welcome everyone to LEMD's live educational series. We're so glad you're here with us this evening and you were able to join us where we have the opportunity to learn and grow together. I like to say here at LEMD, we're not just a telehealth company. We're a company focused on helping people live longer, healthier lives. And our mission goes beyond providing great products and services. We believe that education is key to improving health and well-being and lifting up our communities together. Through these weekly educational series and sessions where we bring the experts in the field of longevity, healthcare, and wellness, we hope to give you the tools and knowledge necessary and empower all of you to live longer, healthier lives. Tonight, I have the pleasure of speaking with Dr. Leann Poston, a distinguished medical professional, educator, and writer with over 30 years of experience in healthcare. Dr. Poston's extensive background in both medicine and education truly sets her apart. As a licensed physician, she's practiced clinical medicine, but her passion for helping others extends far beyond the clinic. She's also made significant contributions in medical communications, education, and advising. She combines her expertise in traditional and functional medicine to write extensively on GLP-1s, obesity treatments, longevity, and peptides. Dr. Leann holds a medical degree from Wright State University, Boonshoff School of Medicine, an MBA from Raj Soin College of Business, and a Master's of Education from Wright State University. Very impressive, Dr. Poston, I have to say. Dr. Poston lives in the Midwest with her family. She enjoys traveling, hiking, and Peloton classes. I know we talked about that. Welcome, 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 Dr. Poston, to our
Thank
community.
you.
Thank you for being here. Thank you, thank you. Before we get started, I just wanted to ask you, how did you come about to become a doctor, a physician? Give us a little background on yourself. What made you so passionate about GLP-1s and peptides? Just tell us a little about yourself.
Sure. First of all, call me Leann. But I've always wanted to go to medical school and I always wanted to be a doctor. So I went to medical school like I had planned, went to residency, did pediatrics. I thought that would be the best field for me because I love children and I love families and working with families. I found that it was great, except for I needed more research and ability to ask questions and try to get answers. And I just wasn't finding that in general pediatrics. So I switched over to academic medicine back in 2002, I think, and have been there ever since. And so I've worked as an assistant dean in a medical school. I've also worked freelance. I've worked for pharmaceutical companies, businesses, just a wide range of people, and looked at medicine from a bunch of different angles. My interest in obesity, I love Peloton. In case you wanted to know one personal thing about me, I probably do, 10 or 15 hours of Peloton a week and run about 28 miles a week. I think that there are so many things we can do to improve our health. And that's where I got more interested in functional medicine and more interested in what I think of as lifestyle medicine, basically enabling us to advocate for ourselves to improve our health.
Well, thank you for your contributions in the field of medicine and healthcare, and thank you for joining us tonight. So let's dive in. I'd like to ask a series of questions, and please share with us what role does obesity play in modern longevity, and why is it considered a critical health concern?
Yeah, obesity, there is about 200 different diseases associated with obesity. Obesity is either a contributing factor to these conditions, or the inflammation from excess body fat is contributing to these conditions. Up until we had the GLP-1 medications available, I can tell you as a clinician, there wasn't much we could offer. We could tell people eat less, exercise more, and that was what we could tell them. We know that the calorie in, calorie out energy balance model is not accurate. We know that people's brains change, their metabolism changes when they gain weight. We know that you can improve your diet, you can exercise more, but that's not going to take care of the vast majority of obesity. We have so many contributing factors, from the environment that we live in, to the chemicals that are in foods, the additives that are in foods, the easy access to food that we have. There's always the genetic contributors. Some of the research has shown that people with one parent with obesity have a 3 times higher risk of obesity, and people with 2 parents with obesity have a 10 times higher risk of obesity. So there's just so many factors that are contributing to it. We know also that excess body fat is not just fat. A lot of people give the idea that, okay, I've gained an extra 20 pounds and I'm, the health risk of gaining an extra 20 pounds is the same as carrying a 20-pound barbell around with you all day. That's not right. Okay. Fat is metabolically active, especially your body fat that's around your organs, your heart, your liver, and your intestinal tract. It secretes chemicals that are going to affect your entire body. It increases inflammation and it affects your brain. And then we know now too that the microbiome that's in the gut is interacting with the chemicals that your body is secreting, and then the hormone levels that change throughout your lifetime. And all of that makes obesity a very complicated disease that needs to be much better understood. And I think we're reaching the point with the GLP-1s that we are just on the cusp of actually making some progress now in treating obesity. So I'm glad to be involved in that.
Yeah, I love what you just said. Fat is metabolically active. Can you elaborate on that and how it works and what it does to your hormones and your gut microbiome, and just tell us like holistically what fat does to our body? Can you elaborate a little more?
Well, you've got 2 places that you have. Well, first of all, you have brown fat and white fat. Brown fat is good fat. We have more of that when we're very young. People try all kinds of different ways to increase brown fat. The most likely place for you to have it is between your shoulder blades on your upper back. Most of us don't have very much of it. People are trying different ways to increase brown fat by, the cold plunges and things like that. And stressing your body by, as far as body temperature is one way that they think might work it. So that's one kind of fat. As far as the white fat, which is the kind we're referring to here, the location of the fat makes a difference also. Fat that is underneath the surface of your skin, the subcutaneous fat, is not really a problem. All of us carry some fat under our skin. It actually makes your skin look better. When you lose it as you get older, you start to get more of a wrinkled appearance to you and things like that. So we kind of don't mind that fat, and it's not metabolically active like the organ fat is. Organ fat, for the longest time, they thought the risk was that fat around the heart, for example, was keeping the heart from contracting the way it was supposed to. Fat around the liver and the gut was compressing blood vessels. And then it was only when they started understanding that there are all kinds of what are called cytokines, which are these chemicals that trigger inflammation that are released from fat. And inflammation throughout the body causes so many things. Inflammation is what's causing your blood vessels to be damaged, increased cholesterol, deposits there, blood clotting there, heart disease, liver disease, increasing your risk of strokes. That there's just so many health issues that are a result of inflammation. So the goal was at one point was to try to understand what chemicals were released from fat in order to see if there was a way to control those chemicals and the chemical release and possibly improve overall health that way. That really hasn't worked out that well. And the reason it hasn't worked out is because we're just so complex. Human beings are very complex. So what is causing me to have more organ fat may not be the same reason that you have more. It could be because my microbiome is different than your microbiome. Interestingly enough, the bacteria that are in our gut are not just hanging out there. They're not just chewing up the cellulose and other complex carbohydrates that we have that we can't use for nutrients ourselves. They are actually releasing chemicals that also can increase inflammation, but they also change your hormone levels. So they can help determine whether you're hungry, not hungry, what foods you prefer, whether you want more carbohydrates or not, because these bacteria want to feed themselves. And so they will trigger your appetite that way. In your brain, you have the reward pathway, in your brain. Some of us, our reward pathway is so much stronger than other people. Some of us can walk past that bag of potato chips and never give it a second thought. Some of us, we walk past potato chips, and especially if you smell it, that's the end. It's going to be on your mind for the next couple of hours until you start eating some. And it's going to take quite a few to get you satisfied too. If you didn't know, potato chips are my thing. So anyway, that reward pathway and the GLP-1s, they're actually using those for and testing them for other kinds of reward pathway driven addictions besides food because of that.
Yeah,
Then
no, we're gonna get into that for sure.
well, and then there's the genetics too, which is another hugely complex thing because we have the genome, which has now been mapped, as most people know. We know the A, T, C's, and G's and the sequence of them. We have these companies that will map your genome and tell you all kinds of interesting things about the traits that you have and your risk of various diseases and stuff like that. But even more importantly, as far as obesity is concerned, is the epigenome. The epigenome is on top of the genome, is what it means. And it is a series of proteins that are around, and histones, and they're around your DNA. And these, you can put methyl groups on or acetyl groups on. Methyl groups will suppress the DNA. Acetyls will kind of open up the DNA and allow those genes to be read and used to make proteins. So there's a ton of research looking at that now because we know that what you eat affects your epigenome. We know that the environment that you live in, your emotional status, medications you may be taking, your gut microbiome, all of this can affect your epigenome. And that's why, some of us can lose weight easier and some cannot. And that's what's so nice about the GLP-1 medications, because there's a large percentage of the population that have done the eat less and exercise more. And they've done it multiple times and done it for years. And it's just not working.
So let's take a step back. Maybe you could explain what peptides are and then just break it down a little bit further and tell us what GLP-1s, how they work, what they do, and their role in weight loss. But let's just take it a step back and tell us about peptides first. Yeah.
Well, peptides, what a peptide is a short series of amino acids. That's all it is. So when you make a peptide, or a company makes a peptide, frequently what they'll do is they'll take a hormone that is naturally in humans that does something, usually a hormone that decreases with aging. And a lot of them do. And a growth hormone is a good example of a hormone that does decrease with aging. We've tried replacing growth hormone. That's a peptide because it is a series of amino acids and you're using that to try to replace it. The problem is it causes all kinds of health issues, so don't do it. The only people that it's a good idea for are children that are growth hormone deficient to treat a disease. But there are also growth hormone releasing hormones like sermorelin that is also a peptide. And what that does is actually try to stimulate your natural release of growth hormone in order to try to combat some of the things that are associated with a decrease in growth hormone, like a decrease in muscle mass and an increase in body fat. Technically, any medication that is a protein is a peptide. So all of the GLP-1s are peptides also because they are made up of series of amino acids. The reason, I commonly get asked, why do we have to inject them? Why can't we just have a pill? It would be so much easier if we have a pill. And they're working on developing a pill, and there is some progress being made there. But the reason that they are injected is because proteins are broken down by stomach acid and enzymes in the stomach into the amino acids that make them up. So if you would just swallow a peptide, it's going to be broken down into its composite amino acids and then absorbed through your gut into your circulation, and then can be used to be reassembled back into that peptide again. By injecting peptides directly into the circulation or into the muscle and then ultimately into the circulation, you bypass the gut. That's what you're trying to do there. So peptides, all they are is a short sequence of amino acids. Pharmaceutical companies and other manufacturers just try to take the sequence that matters the most, get rid of anything else, and see if that will work to kind of replace whatever it is that you're lacking.
So let's talk about GLP-1s and how they contribute to weight loss. So we have people here who are currently using GLP-1. Some people are not familiar with it at all. They're interested in learning more. Can you tell us what GLP-1s do and how?
Well, there's three big GLP-1s right now, and I'm going to use the generic names for them because I can never remember the brand names that they go with. Okay, so there's the liraglutide's the oldest one. I don't know that it's used as much anymore because semaglutide and tirzepatide have both been found to be more effective. The weight loss potential for both of them tends to be a little bit higher. So all three of them do the same thing, but all three of them were designed for diabetes because one of the major things with all three of them is they can increase insulin production. So if you think about what it is that you're wanting your GLP-1s to do, insulin increases body fat. That's why people who have type 2 diabetes that are injected with insulin will gain weight. They try not to, but they gain weight because insulin is a hormone that stimulates growth, is what it does. Whether it's fat growth, muscle growth, or whatever, it stimulates the growth. So at first, it doesn't make any sense that a GLP-1 is going to increase insulin and cause you to lose weight because of that. So I wanted to get that out of the way first. It also affects glucagon hormone. Insulin and glucagon are opposites. So when you eat something and your blood sugar rises, insulin is going to usher that glucose or sugar from your bloodstream into your body cells. Usually muscle and liver are the big consumers. Your brain consumes some too. But what it does is it ushers it into your cells so it can be used for energy. That decreases the amount of glucose in your blood vessels, which is definitely what you want to do because glucose is an irritant. It irritates the lining of blood vessels and it also sticks to proteins. And when it sticks to proteins, it forms a sticky covering on the inside of your blood vessels, makes it a good place for platelets and cholesterol and other compounds to collect and cause you, things like blood clots and damage to your blood vessels. So you definitely want to get the sugar out of your bloodstream and into your body cells. Glucagon does the opposite. It it causes your liver to produce glucose, and it also helps glucose leave the liver and going out to your circulation. So GLP-1s increase insulin and decrease glucagon. And the end result then is to get sugar out of your circulation and into your body cells. Now, that is used for diabetes. And it also makes it so that we can control your blood sugar without the effects of insulin, because the combination of its effect on insulin and glucagon together make it so that it doesn't have quite as great an effect on weight as insulin does alone. In addition to that, though, that wouldn't be enough to make an effective medication. So the other things that GLP-1 medications do is they have receptors along the stomach and they slow stomach emptying. And so as your stomach slows down and doesn't empty quite as quickly, you feel full longer. It's just like a lot of people will say if they eat fatty foods or proteins as opposed to carbohydrates, they stay full longer and they don't get hungry quite as much. And that's just because those compounds or those macronutrients are a little bit harder to break down and they stay in the stomach longer. So it makes sense that slowing your stomach down and leaving food in there a little bit longer is going to make you feel full longer. The problem is that's what contributes to your side effects. So for any of you who've taken the GLP-1s and you felt nauseated, or you may have had vomiting, or you have had stomach aches or indigestion, especially when you first start taking the medication or when you increase your dose, it's that property of the medication that causes it. That side effect tends to go away after you adjust to the dose, but that's what it's from. GLP-1s can also slow down the rest of your intestines. So some people will say they will have constipation, but just like Benadryl can cause some people to be hyperactive and some people to be sleepy, GLP-1s can cause some people to have constipation and some people to have diarrhea. So either one of those are another side effect that can occur. All right. And then in addition to causing the pancreas to release more insulin, decreasing the amount of glucagon, slowing the stomach, we know that GLP-1s also affect the brain. They more so than any other area as far as what we're looking at here, as far as cravings and appetite. I just saw a research paper, a 2024 research paper, where they were talking about GLP-1s and the brain and its effect on the brain. And in this research paper, they were saying that non-pharmacologic doses, which means the amount of GLP-1 that all of us who are not taking GLP-1 medications have, is not enough to affect the brain. They said you almost have to have take the medication in order to get levels high enough to affect the brain, which would make sense then, because you would wonder, why is it that some people who are not taking medications, don't have that same effect? So altogether, then the medications decrease appetite, decrease cravings, increase insulin, decrease glucagon, slow stomach emptying, and therefore decrease your appetite.
Well, I want to touch on the lipolysis process and how it promotes fat burning,
Yeah,
especially
tirzepatide's
different
a
fats.
little bit more known for that than semaglutide is as far as fat burning. And that's been a really interesting because initially they didn't think it did that. Initially, what made sense is it is the insulin release. What would it make sense that insulin's going to do to fat? It's going to increase the amount of fat that you're going to store, right? Because insulin, what it does is take sugar into body cells, and excess energy of any kind is going to be stored. And how do we store it for the most part? I mean, we store some as glycogen in our muscles and our liver, but once those stores are full, we store it as fat. So initially, most researchers were thinking that GLP-1s are actually going to not affect fat breakdown, but it does. And it preferentially breaks down fat, especially tirzepatide. So I'm not sure that we know the mechanism of how it does do it, but it does. And then, you may have heard the term skinny fat. If you've heard people talking about taking GLP-1s and being skinny fat, well, that's one of the things that they're referring to, is because the GLP-1s do seem to preferentially break down fat, people are losing weight, but they're also losing some muscle mass too. And so, one thing that you do want to do if you are taking the GLP-1s is try to still stay with your resistant exercises specifically in order to maintain as much muscle mass as you possibly can while you're taking these medications.
So, from what I understand, these classes of medications, incretins, they're not new. They've been around for a very, very long time. We have enough data, research, and study on them. But can you share with us who would be an ideal candidate for GLP-1 medications? And what factors should be considered when prescribers are
Well,
prescribing these medications?
and the reason incretins have been around for a long time is because an incretin increases insulin release. And so technically insulin, and we kind of know how incretins are going to behave because of insulin. We see what it does, and we would expect that medications that are going to increase insulin release are going to do the same thing. So most of these medications at some point were used to treat type 2 diabetes. That was their initial purpose. That's what they were initially tested on. I believe it was semaglutide's manufacturer that its impact on obesity was kind of a serendipitous finding. What it ended up noticing is that when it was using semaglutide to treat people with type 2 diabetes, they were losing weight. And so they ran a research trial to see what if we increase the dose of semaglutide, would they lose more weight? And they found that they did. So that's where it kind of got started. We have the history of it being used for a long time for type 2 diabetes, but now it's reached the point where we understand that it works very well for obesity as well. As far as an ideal candidate, you are supposed to have a BMI of 30 or higher as your baseline, but there are some caveats with that, which I'll get to in just a second. BMI is weight for height. It's very useful as far as a generalized screening tool, but you will hear a lot of people have a lot of complaints about BMI because people who exercise, lift weights, things like that, their BMI is going to be higher because they have more muscle mass, but they shouldn't be losing weight because then they're going to lose that muscle mass. So I know a lot of people will complain about BMI and say, why is that a criteria? It's a criteria because we have to have a criteria. Just like, you can just as easily say, well, the cutoff for fever is 100.4. Well, my body temperature normally runs at 97. Why would I be 100.4 when yours normally runs at 99? It's 100.4. It's just a number that we have. So 30 is your baseline. Anyone with a BMI over 30 is considered a candidate. Now, other people who are candidates are people with a BMI of 27 or higher that have a weight-related medical condition. So what does that mean as far as a weight-related medical condition? It's any condition that obesity is going to contribute to. And if you think about that, there's a lot of possibilities. So the big ones that they talk about are high blood pressure, abnormal blood lipids, type 2 diabetes are the big three. But Are there others that, people could use and say, well, I have this, and it's also weight related. My BMI is 27. Am I a candidate? Possibly so. So, if you do have a BMI that's over 27, I would talk to your doctor to find out if you meet the criteria for it, because there are more weight related medications or conditions than you would think. Who shouldn't be taking the medications? Now, I've got this here because I want to make sure I don't miss anything, but anyone with a personal or family history of medullary thyroid cancer. That was a little interesting because it was found that the GLP-1s increase the risk of medullary thyroid and other kinds of thyroid cancers in rodents. They have not seen it in humans, but only in rodents. But because it did show up in the rodent studies, they do list that as a possibility. Multiple endocrine neoplasia syndrome type 2, which is a very rare condition. It's genetic. A history of pancreatitis, and that's inflammation of the pancreas. We know that the GLP-1s act on the pancreas. They increase production of insulin. If you have an inflammation of the pancreas or some condition that's, affects the pancreas, it is possible that the GLP-1s can aggravate that. So if you've had pancreatitis, you need to talk to your doctor. Allergies to GLP-1 or any of its components, which makes sense. You don't take a medication with an allergy. Gallbladder disease. Now, I've seen this with some of the GLP-1s and some I haven't. So if you have a history of gallstones or gallbladder disease, make sure you let your practitioner know that you have that history so they can make a decision based on that. Other ones that you want to discuss with your doctor but won't necessarily keep you from getting the medication are suicidal behavior or ideation. There is some indication that at least in some people, GLP-1s can increase the risk of suicidal ideation and behavior. So if you have that, GLP-1 should never be used to treat type 1 diabetes. Type 1 diabetes is that genetic autoimmune, or it's not genetic, it does have a genetic predisposition, but autoimmune diabetes. It is more common, presents typically between the ages of 10 and 14, and the pancreas just stops working, and you need insulin to treat type 1 diabetes. So that it's not a candidate for that. If you're pregnant or breastfeeding, there's just not enough research on pregnant women or women that are currently breastfeeding to know. We were talking earlier as far as clinical trials and why is there not this research? Because in the past, clinical trials were mostly done on men. And the reason that they were mostly done on men was because they were mostly done actually on 20 to 30-year-old military recruits that all had pretty much the same body size, muscle strength, and everything else. And the reason that researchers wanted to use that population, first of all, they were available and they didn't have much say in whether they participated or not. But the other thing that was really important was it got rid of a lot of variables. You didn't have to worry about estrogen and progesterone levels throughout your cycle. You didn't have to worry about pregnancy or birth control pills or what effects they would have or any of that. So unfortunately, that's why a lot of these medications don't have the data that we need for pregnancy and breastfeeding. And we have to know that the risks versus benefits are in favor of testing the medications. So yes, obesity can increase your risk during pregnancy, but does it increase your risk enough to make taking a chance on a GLP-1 worth it while you were pregnant? I don't know the answer to that.
Now I get asked this question quite a bit. Do I have to stay on these medications for the rest of my life if I do overeat typically, and I've lost my weight on GLP-1s? Do I have to stay on these medications for the rest of my life?
That's a really good.
What are the long-term implications? Do we have the information, the data, the science to tell us if these are safe long-term?
We have 2 years of data. So that, initially the clinical trials start off with a couple of months. They see what happens there. Then they go up to a year. They see what happens there. And now we're up to 2 years of data. And at this point, there's probably even more data, but there's at least 2 years that are published data. And what they did is they took people who took, I believe it was semaglutide is what most of the research has been done on the crossover, but tirzepatide recently reported theirs as well. So it follows the same as semaglutide. But they took people who lost weight on semaglutide. And the average weight loss on semaglutide is about 15% body weight. And the average weight loss on tirzepatide is about 20% body weight. But they took people who had lost the weight. And then when the trial was over, I think both of them were 1-year trials, they took those people and they randomly either got a continued course of semaglutide or they were switched to the placebo to see what happened. And what ended up happening was the people that were on semaglutide and continued taking it lost an additional 5% of their body weight over the next year. So it showed that people could continue to lose weight even though they had been on the medication long term. But the people who stopped taking the medication gained about 5% of their body weight back again. So it also indicates that unless you make lifestyle changes and are able to change your environment in order to support your new body weight, and your chances of gaining weight back are high. So that brings up another question. How much medications do we have to give, and how long do we have to give it in order to, because obesity, I work for several medical societies that research in endocrine type disorders and endocrine disorders. And that's the thing, is that their big statement about obesity is it is a chronic disease. It is no different than high blood pressure or any of the other chronic diseases. We don't stop treating blood pressure when we get your blood pressure normal. We continue treating your blood pressure. If you lose weight and you change your diet and your risk factors for high blood pressure decrease and your blood pressure decreases, then what do we normally do? We start decreasing your medication. We see how much we can decrease your medication and still maintain your blood pressure within normal range. Some people will come off their blood pressure medications completely when they lose weight because the environment has changed enough. Their weight loss is, the chemicals that I mentioned before that are released from the body fat, all of that has improved and they don't need the medication as much. So I would anticipate the same thing's going to happen with our GLP-1s. What's going to happen is when you reach whatever the goal is that you and your practitioner have set as far as your weight loss goal, and you get there and you start talking about, do I need to use this medication long term? I would anticipate you will see a slow decline in your medication dose to see what happens, just like we would expect a slow decline in your blood pressure medication to see what happens. And if you're able to maintain your weight, we will, gradually decrease you a little bit at a time. Some of you will be able to come off the medication, do great, may never ever need it again because things were improved in your body, whether the effects were on hormones, whether they were on, cytokines, whether it was improved inflammation, whether it was epigenetic changes. It could be all of those, any of those, some combination of those things, but you don't need the medication anymore. Some of you are going to find that once you come off the medications, you start gaining weight again. And you have to decide what you're going to do at that point. Are you going to try to go with the minimum amount of dosage that you can get to, and that's a conversation to have with your doctor, but that's what I would anticipate will happen.
Okay, great. I want to leave some time for our discussion around peptides, but we get asked this question quite often. Well, what's the difference between tirzepatide and semaglutide? How's their mechanism of action different? Why do you get better results out of tirzepatide? Can you elaborate on that?
Yeah, I can do that one really quickly. Tirzepatide's got it's a twofer, and semaglutide's a single one. Semaglutide's a GLP-1 receptor agonist. So what it does is it binds to the GLP-1 receptor and stimulates it. And it has the effects that we mentioned earlier. Tirzepatide is also a GLP-1 receptor agonist, but in addition to that, it's a GIP. And I always got to keep track of what that medication is. Anyway, GIP, we'll just go with that. But it's another hormone that's produced in the gut that also does some of the similar things. It does help increase insulin production, and it does change the way fat is metabolized. So it seems that the reason that tirzepatide has slightly better results is because it's combining a GIP and a GLP-1.
Okay, and as far as their efficacy, can you talk to us a little about?
Well, they're both very good. The average weight loss with semaglutide was about 15% body weight. So, and that's over in the 8-step trials that were done, that was over 68 weeks. The average weight loss for tirzepatide was a 72-week trial and it was 20.9% body weight. So, to lose a fifth of your body weight over a year, or actually that one would have been 2 years, is pretty amazing results. And we if you could look back at the other weight loss options we've had up until this point, we've not been able to get anywhere near that kind of results.
Mhm, mhm. We briefly touched on side effects of these medications. I know I have used tirzepatide. So many other people have used tirzepatide before. My side effects have been minimal on tirzepatide, and it's not necessarily true for everyone, right? Some people have no side effects on semaglutide, have side effects. But can you talk to us about side effects of the different medications? Why do some people experience it on one, not the other? And what can we do to minimize the side effects?
Now, the biggest side effects are due to that delayed stomach emptying that I mentioned earlier. If you keep food in your stomach longer, you're going to feel bloated. You're going to increase the risk of reflux or stomach contents going up into your esophagus and giving you heartburn. It's going to increase the risk of nausea. Some people will even experience some diarrhea. Um, Semaglutide and tirzepatide both also affect how quickly the muscles in the intestines push contents from the small intestine on down to the colon. Some people will experience diarrhea and some with constipation from it. All of those side effects I would treat the same way that you would treat them if you got them any other way or from any other medication. So knowing that your stomach is full and it's not emptying quickly, of course, you want to go with small, frequent meals. You want to avoid the fats because fats tend to stay in the stomach even longer. You want to stay upright for about 30 minutes or so after you take your medication and after you eat in order to try to prevent reflux and stomach contents going up into your esophagus. Make sure you chew your food thoroughly because that will help break it down worse before it gets to the stomach. Talk to your doctor about any other medications that you're using or taking for any other reasons, because there are some medications that actually slow the stomach even more, and that may be compounding your problem there. If you have constipation, I mean, I can tell you, as a runner, the biggest cure for constipation is a cup of coffee followed by running a mile. That'll do it every time. But if that's not for you, coffee still works and walking works really well too. Increasing fiber in your diet is a great choice because fiber goes undigested through your colon and helps bulk up your stool and make it easier. As far as diarrhea, you still want to drink plenty of fluids because with diarrhea, you're going to lose fluids. So you want to stay well hydrated, but try to avoid the excess fats because fats do tend to worsen the diarrhea. And side effects are most common when you first start the medication and when you first increase the dose. So when, expect that if you're going to be prone to it, those are the time frames you're going to see. They tend to go away as soon as your body adapts to the dosage. But talk to your healthcare provider if you're seeing those side effects, because possibly they can, adjust your dose a little bit to make it a little bit more comfortable for you.
You touched on this a little earlier about these medications and their effect on mood. And I came across a Reddit article earlier today, and it's on Reddit, so it must be true. But a lot of people are reporting the benefits of these medications on ADHD and other types of the mood benefits of these medications. Have you come across anything and any reports on these medications and their effect on ADHD or
I
actually
haven't specifically on that, but we know it does affect the brain and we know it does affect the reward circuit. So is it outside the realm of possibility that it's going to have a lot of different uses as far as, mood disorders and any of those things that are dopamine type dependent? I don't think it's outside the realm of possibility at all, but I don't know of any research yet at this point that supports it.
interesting? And you touched on depression, suicidal ideation. Why
Mm-hmm.
is this medication not recommended for people who have reports of these?
Because the biggest problem with depression and suicidal ideation is we don't really know what causes it. I mean, you may have all heard about the hormone imbalance theory that we have to increase your serotonin and change your levels of dopamine and norepinephrine, and people who have an imbalance of those hormones are the ones that are more prone to depression or anxiety and mood disorders and things like that. And then we've got all of these pharmaceutical products that are used for treating depression. And if you know somebody who suffers and lives with depression on a daily basis, you'll know that a lot of times the medications don't work. And they have to try and trial and error to see if they can find something that makes a difference. So that's the scary part about it, is we don't know what exactly causes depression and suicidal ideation. And then to add a medication that may affect mood and may affect the brain, and we don't know which direction it's going to affect it. So that's why it's not a contraindication to take in the GLP-1s, but it's a conversation you definitely want to have with the person that's prescribing it, so that you can weigh the risks and benefits. Because, you know, obesity is a disease also. It also has a ton of health consequences. So should we just say that we shouldn't treat that because of the possibility? You know, no, it's like anything else. We have to, everything you put in your mouth has got risks and benefits. You know, walking out the door has got a risk and benefit. You know, you get out of the room, but you've got a risk. Something could fall on you. So, I mean, that's the way to look at life. There's everything has a risk and benefit.
Yeah.
Talk to somebody who knows your medical history and see if your benefits outweigh your risks.
And you should always involve your primary care physician when taking these medications. Okay. We here at Ellie, perhaps we have doctors that are prescribing these medications, but your primary care physician should be involved in because they have all the data points, right? They have your entire health history.
And they know you, and they know how you manage things, and they can be your contact also. You know, if you feel like your mood has changed, or you feel like something's not right, you need to have somebody that you can consult and talk to make sure that you're not putting yourself at risk.
And I've heard both sides of the spectrum. Thank you for touching on that, because I've heard people who have said, you know what, my mood has completely improved. That brain fog has completely gone away. So you just don't know. And that's why this medication is to really be personalized for you, your journey. The goal is not to go up in dose. It's to find your sweet spot, correct? Can you touch on that also? Why that sweet spot, and why the goal of the medication is not to go up in dose, but like listen to your body, figure out where you are. That's why we do the 3-month assessments to see where you are in your journey, and then we personalize the next 3 months. But can you elaborate on that a little?
Right. I think a good thing to compare it to would be caffeine. Okay. And the reason you may think, well, caffeine, that has nothing to do with GLP-1s, but you're right, it doesn't. But it does provide a lot of the things you need to consider. Some of us are fast metabolizers of caffeine. Some of us are slow metabolizers of caffeine. Some of you have 1 cup of coffee, you are wired for the day, you're up all night. You need a lower dose, okay? It has too great of an effect on you. Just because your neighbor can drink 2 cups doesn't mean you should, okay? Other people, they can drink 10 cups of coffee all day long. As soon as their head hits the pillow, they're gone, they're done, okay? They may need even a higher dose of medication. What's the difference between these 2 groups of people? It is changes in their DNA that make it so that the number of receptors they have for caffeine differs, how well caffeine binds to their receptors differs, how caffeine is metabolized in their liver and kidneys differs, and the same with your GLP-1s. For all of you, you know, the number of GLP-1 receptors you have in your body are different from other people's GLP-1 receptors. The locations of those receptors are going to vary. How fast the medication is metabolized by your liver and excreted by your kidneys is going to vary. So you may take 1 dose and have a blood level that's exactly the same as someone who's taking 1.5 or 2 times as much as you are. You know, it all has to do with those factors.
Okay, so let's talk about how GLP-1 receptor agonists and other peptides integrate into a holistic approach to longevity, considering nutrition, exercise, and other lifestyle factors.
Well, and that's really important, because if you look at the clinical trials for semaglutide and tirzepatide, the researchers made a really big point of saying that everybody in both groups, the placebo group and the treated group, were receiving psychological counseling and nutrition advice. They were also on a reduced calorie diet, and they did 150 minutes of exercise every week. So to get the clinical trial results, if you have to replicate the clinical trial setting, right? So that means in addition to using semaglutide or tirzepatide to help with your weight loss journey, it's really important to try to also incorporate that reduced calorie diet and exercise. Whatever people commonly ask me, what kind of exercise should you do? Anything that you will do, you know, anything is better than nothing. If you're going to walk 20 minutes a day and that's what you can commit to, just do that. If you could do a little resistance exercise also to kind of boost your muscle tissue a little bit so that you don't get that skinny fat that people refer to, that's great also. But the other thing that's going to be really important is when you do reach your goal and you do want to come off the medication, you know, that those nutrition and lifestyle changes that you've been able to incorporate it's going to be much easier to continue using them long term. So I agree that medications are very important, but they're one piece of the puzzle to help with weight loss and obesity.
Mm. So let's talk a little about, actually, I want to answer someone's question. They asked, when people ask how is semaglutide and tirzepatide different from the brand names that are out there, maybe you could touch on that briefly.
So
About
I would
talk about
assume you're,
compounding pharmacies as
yeah,
well.
you're referring to compounded medications as opposed to generics. So we have three different classes of kinds of medications. The brand name medications are the ones that the clinical trials are run on. Those are the ones that the pharmaceutical companies have produced and tested and gone through all the FDA approval process and all of that stuff. The reason that brand name medications are so expensive is because of that. Pharmaceutical companies have to put tons of drugs through tons of testing in order to come up with a product or two that actually is going to work. So there's a lot of luck involved there, and luck is expensive and when you're developing drugs. So those are your brand name medications. So if you ever wondered why are they so expensive, that's why. If you've ever seen the regulatory paperwork for submitting a new drug application, I mean, it's hours of medical writing to get those done. Once the patent, and that's why brand name medications are given a patent. They're given a patent to protect them for 10 to or 12 to 15 years so that they can kind of recoup some of that medicine from, or some of that money from paying for the clinical trials and the testing and submitting the applications and all of that. So generics are only allowed to be manufactured once that period of time is up. And that's why generics tend to be cheaper. And there's even some ways to support one generic medication over another generic medication. I mean, there's a lot of politics involved in this too, but the simple answer is between the two of them, that's all that there is to that. Compounded medications. Now, if a medication is on the FDA's short list, a medication, the company cannot keep up with demand and they cannot fulfill their backlog, then that medication can end up on the FDA list. If that medication is on the FDA list, then compounding pharmacies can produce that medication themselves for individual patients is how they write it, is because they're compounding pharmacies. Theoretically, they can develop the dose in whatever dose you need. They can add things like vitamin B12. They can add vitamin B6. Vitamin B12 is commonly added to the GLP-1s because it has been shown to help with nausea. So the thought is that if you add that to semaglutide, that it will actually help with the side effects. As long as these medications stay on the FDA list, then the compounding pharmacies in the US are permitted to make it. And they still require a prescription. The difference between a compounded medication and a brand name medication is, and even, I mean, a generic medication has to be identical to the brand name medication. A compounded medication does not have to be identical to the brand name medication. So the thing that's a little bit different is the brand name medication went through all the FDA approval process. Compounded medications are not regulated by the FDA. Now, the labs that produce them are regulated by good manufacturing practices and by pharmaceutical boards, but not by the FDA. And the reason for that is if one person needs 2 milligrams of something plus B12 and somebody else needs 3 milligrams of something plus B12, how are we going to go and do a clinical trial that shows that 2 milligrams plus B12 works just as good as 3 milligrams plus B12 and submit all of the necessary paperwork and everything through the FDA in order to test every single possible combination we can come up with? So that's kind of the difference there.
Mm. Well, thank you for elaborating on that.
Well, and that's why it's really good that people are buying medications from online companies and pharmacies that have the reputation for making sure that where they're buying it from is following good manufacturing practices and using the right medication bases and stuff.
Thank you for touching.
I'm sure you've all seen the for research purposes only online. They're it's a little risky.
Not be using those, right?
No, it's a little risky. I mean, you're injecting things into your body, and yes, we know that they're saying for research purposes only, you kind of wink, wink, go ahead and use it, but that's risky. You don't know where they got it from.
So can you tell us about why and how peptides are available through, so let's switch gears and talk about peptides. We have a few minutes left. You told us that peptides are just chains of amino acids that come together and they trigger a series of different events throughout the body. Let's touch on some of the peptides that we offer. So
Okay.
Samoralin, maybe you could tell us what Samoralin does, and then PT141. Why and how do compounding pharmacies have the ability to compound peptides? Maybe you could touch on that.
Yeah, peptides are not in the prescription drug category. So they're not in that patent new drug application pathway that the prescription medications are. Now, PT141 is a little bit different because there is a form of PT141 that is a prescription medication. And so it did go through its pathway and stuff. But people are using PT141 off label. Now, off label always sounds scary to people when I mention things are used off label. I can tell you, as in pediatrics, 80% of what we use is off label. Why? Because if you don't think they're going to do clinical trials on women, do you think they're going to do them on children? So what they do is they do the clinical trials on the men, and then what they do is they decrease the dose for children. Okay, so any I'm trying to think of a good example, like some of the cold medicines, we use them off label, prescription cold medicines in pediatrics, because they were tested in adults. But we know that half the dose may work well for a 12-year-old, and a quarter of the dose may work well for a 6-year-old, and a 6-year-old and a 12-year-old are just as miserable as an adult with a cold. So we use it off label for that. So that's kind of an idea of what off label means. So what people are doing is they're taking medications like PT141, which was used for in women, premenopausal women that had decreased libido. It's the prescription form of it. And they're like, well, but what else could we use it for? We know the medication has been tested. We know that it does improve libido. So what else can we use it for? And testing was done in men. Some testing, this is new research and everything like that. And some testing is being done in postmenopausal women. And the thought is, can we use PT141, which is prescription for some people, but possibly use it off label for others? So that's how that one came about. Samoralin was a prescription medication way back. I don't even remember how long ago it was a prescription medication. But there was a problem with it and had nothing to do with the medication and its safety or anything like that. It was actually used to treat growth disorders in children. I think that if I remember right, don't hold me to this, but I think what ended up happening was the company made another product that was better for what they wanted to use it for. And so it didn't make sense to continue to pour money into Samoralin. And so they just stopped manufacturing it. But if you look at some of the research articles, they actually make a point of saying it was not discontinued because of any concerns. It was a business decision. But Samoralin, what it does, it requires a prescription because it is an injectable. Anything that you inject into your body does require a prescription, even if it was a protein, because people commonly say, well, if it's just a protein, why do I need a prescription for it? Why can't I get it myself? Because it is an injectable. But with Samoralin, what it does is growth hormone is released if it's released in pulses. If you take exogenous, so outside the body, growth hormone, well, it's going to suppress your brain from making growth hormone. That's not a good thing. And that actually causes lots of side effects and can cause some serious medical issues. Samoralin, what it does instead is it stimulates growth hormone releasing hormone. So it stimulates the hormone that is a natural part of the feedback loop that stimulates growth hormone release. So basically what it's doing is helping your brain release its own growth hormone. But importantly, it's staying within your body's own feedback loop. So it's not overriding the pathway like taking growth hormone by itself would. It's working with that pathway. That's why it's so much safer. So there's a lot of research being done on the growth hormone secretagogues, is what they're called, the whole category of them. And they're all called growth hormone secretagogues just because they help your brain secrete growth hormone. What do we know about growth hormone? We know it decreases when you age. We know it has a lot, and by age, I find this a little irritating, but over the age of 30, get this. So as you age, over the age of 30, your growth hormone levels start to decrease. What happens when your growth hormone levels start to decrease? muscle mass decreases, body fat increases, strength decreases, libido decreases. All of those things tend to happen. So by using Sermorelin, the thought is if we can kind of prod your brain to start producing more growth hormone again, possibly can we increase muscle mass, decrease body fat, things like that, in order to help restore some of that. There is a lot of research getting started on that right now.
I have
And
a
then,
question that came in regarding this specific
okay,
topic. Does overusage or extended usage disrupt the body's natural production of hormones, specifically when it comes to
if we're talking about Sermorelin, the answer would be no. And the reason is Sermorelin is rapidly metabolized, number one, so it's hard to get a really high dose of it. But just it works in your body's feedback loop. And when I was teaching anatomy, the example of a feedback loop I always gave is the heating and air conditioning system. You got your thermostat, your room gets too hot, what happens? Your air conditioning comes on. Your room gets too cold, your heat comes on. Same thing with all of these. I mean, there are hundreds of feedback loops in your body that control everything. But with the growth hormone release, system, what'll end up happening is that you take Sermorelin and increase the secretion of growth hormone, and growth hormone levels increase. Well, that's going to cause some downstream things to increase. And as they increase, these growth factors are what they're called, they'll negatively feed back on the brain and slow down growth hormone production. So with that feedback loop staying intact, you can't override it.
Thank you for
Now,
elaborating.
that's not the case with all medications. There are other medications that you can inject that aren't part of a feedback loop, like growth hormone, like I was mentioning before. If you inject growth hormone itself, then you override the feedback loop. And yes, you can overdose that.
And how about with GLP-1s? We're going back to that topic.
Can you overdose GLP-1s?
Or will your body's natural secretion of GLP-1s and insulin be affected with prolonged use of these medications?
Well, there's two different things there. So one I can answer more confidently than the other. Okay. So prolonged use, I think we've reached the point with us being more 2 years out, not seeing a whole lot of effect with it, and still seeing continued weight loss. And knowing the behavior of other diabetic medications, that we've used medications to treat type 2 diabetes for decades now, and not have had any problems. And they also affect blood sugar and the hormones that control blood sugar. So the length of time, I would say pretty confidently, is not as big of a concern. But you also said, can we overdose on them by increasing the dose too much? I don't know the answer to that. And the reason I mean, because we've tested up to the standard dosage of both semaglutide and tirzepatide. They chose those dosages. They did the first stage of a clinical trial is to test for safety and efficacy. They want to show, first of all, that dose doesn't cause any problems, and secondly, that it's effective, that it does what it says it's going to do. So they tend to run really small clinical trials in generally healthy people to check safety and effectiveness, and then from there go on and run the bigger clinical trials. So I don't think anybody can really tell you that if you took 3 times the dose, for example, of semaglutide, that would be safe and not have side effects. I just wouldn't know.
Oh, wonderful. Well, Dr. Poston, we're about time. Thank you so much. Do you have any last words? We loved having you here and hope you can come back in following weeks, but any last words?
No, I think that, the one thing that I always tell people, that as far as obesity, that it's a very complex disease. If you go to a doctor or anyone else and they tell you it's your fault that you have obesity or it's your fault that you're overweight, I apologize in advance for these people. They don't understand. They were trained in the idea that it's calories in and calories out, and you have full control over your body weight, and you're just not trying hard enough. Please know that is not true. And there are so many things in medicine that people don't know, don't understand. And I'll be the first to admit it. We don't know how a lot of things work.
Well, thank you so much. And
Well,
thank
thank
you
you.
all
This was
for
nice.
tuning in. Thank you so much for being here. We'll we'll continue our discussions in the following weeks. And Dr. Poston, we look forward to seeing your articles published on the Ellie website. Thank you all so much. Have a wonderful evening. Have great weekends. Love you all. Mwah. Have a great evening. Take care.